It's okay. No, I really like these slides because it's really what's happening in a lot of departments, not only in Kuwait, I think. And the fact that what I talked before is about being flat. So lack of recognition, lack of appreciation, less involvement in decision making, and the absence of a professional body or the feeling is about it's really a thing that affect not only technology but also radiographers all around. It's a big problem, and the problem is stated in when I talked about advanced practice, in the fact that there is not a real clinical career ladder. A career ladder doesn't mean that staying in the hospital for 10 years give you more money. It means that you are encouraged to take more responsibilities, to take more money, and to grow up. But it's hard to say. But when I asked the people, there was a really nice thing that happened in Italy. I want to tell you. There was once we had a long talk about how can we perform injection or radiopharmaceutical. After that, there was a really crowded room, and when we asked, everyone was nuclear technologist. When we asked, which of you want to do to inject radiopharmaceutical? 3 people, or about 100. So the fact that mainly a lot of technologists doesn't want to have new or that, and are really reactionist against taking new procedures. And there's a status due to the fact that there's more regulation, a lot of legal issues going on that are taking more responsibilities. Is very seen as why I own enough, I have my family, I have my friends, I can go to holiday. Why I have to put me in danger? And that's a feeling that is really became more more usual than
so it's Italian and
not only Italian. Yes, it's quite can be really good slide for an Italian Congress also. This one.
And in fact, we had a dilemma going on about technologists injecting and approaching the faculty members to educate the student technologists to inject. But in fact, we are controlled by the radiation protection department. And really, the technologists, they don't want to inject. They have enough with exposing themselves, spending so much time with the patient, especially those in the chest hospital where they have people roaming around with 30 millicurie in their gut. Yeah, so they had enough. And I think it's the publication really came right, and I think it speaks for all the technologists around the world.
We test it. Are you all technologists?
Yeah.
How many of you want to inject radiopharmaceutical tomorrow? But more than Italy. But you are sincere because you are not so many of you. So it's a reality. And also you can test that in some countries like Italy, for example, physicians as really use injection radiopharmaceutical are they safe because they have fear of radiologists taking their job. So they use, oh no, but I'm the only one that can inject radiopharmaceutical, you cannot touch me. That's not reality because nurses now can do it in Italy. So I think it's a really bad situation for them. They are trying to adapt. It's not a way. Come on, just to say, injecting radiopharmaceutical is not a job that clinical elevate physician in a clinical way. That's true. Physician must show their ability in decision making, in stating that the PET-CT scan is responsive or not responsive to therapy, in stating that it is a correct scan for diagnosis. This is their job. Injecting radiopharmaceutical is something that does not elevate their status. That's my point of view, and also ENM Technology Committee point of view.
And what about the CT, the technologists doing CT? Are they going through training after their initial training, education, or again?
It's working, yeah. Let's make a test. I don't know if they are allowed. How many of you tomorrow will perform a CT with intravenous contrast? Will want to do it? Okay.
Yeah, CT.
We do it, for example, because we are also radiographers. In many countries, the education is joined together. The problem came that the education is really poor. But what I stated before, there are people that going into work, okay, like it happens to me. Like it happens, just a real story. I went into the nuclear medicine department. Good morning, I'm the new one. Okay, In 1 month, you are alone doing everything, and I didn't study it for that. Okay, I get 1 month to learn everything, and that's. But it was not correct because patient faced a technology that was not able to work properly, and but it happens in some. So what we suggest as a technology usually is to have a common education. We are not against a common education for radiographers, radiation therapists. They are not so agree, but okay, they are not here. So and nuclear medicine technologies. But what we state that we want to have in the basic something that can start at least as a technicians. There is some point, and also the possibility to have a master degree and have something to be recognized as able to do it. So the fact that you have to have a certificate for CT is a good thing in my opinion.
Also, I would like to.
Thanks. The questions for you. Everything Dr. Layla said it, I already knew it, so the question is for you. Dr. Layla have already explained the job description for the nuclear medicine technologist, apart from actually those injections. You have stated for the advanced practice and for the entry level, okay? First thing I would like to ask, when you say advanced practice, what is their job description? Is it the same as Dr. Layla said, but for the level of entry level, I mean in Kuwait? This is my first question. The other, one of the statements that you have mentioned, it was financial reward for more complex clinical work. What do you mean by more complex clinical work in a nuclear medicine department? Because for our graduates, okay, actually when they start their work, they are doing everything, except, as Dr. Layla have said it, except injection or injecting the patients or writing the reports. Thank you.
So if I understood, I hope to focus on your question. So for the first part, we talked about what is advanced practice compared to the Kuwaitian situation. Well, we just talked about it, so about injecting radiopharmaceutical. I don't think injecting radiopharmaceutical is a really advanced practice, but it's fine. But performing diagnostic CT could be considered advanced practice because I'm doing a new diagnostic procedure, and they have seen that there is some resistance in it. Now, you cannot compare. You cannot compare. You have to, when you talk about advanced, the concept that we had with advanced practice, you have to think about the cognitive and the responsibilities. So everything that has a level higher for a cognitive higher level is considered to be considered advanced practice. So you put the proposition for Kuwait, and you state injecting radiopharmacy is a real advanced practice. I don't feel so. Diagnostic CT is a real advanced practice. Yes, it is. Because I am doing that, I have to test protocol and doing something intellectually more. Injected radiopharmaceutical, in my point of view, despite some basic radiation protection issue that we have to understand, is not really making you grow up. But this is my point of view. Maybe someone else could not agree. And on the second one, about complex work, I tell you a story about a girl in UK that was quite a radiographer doing mammographies. And she performed mammography for a while, then became chief of the mammography then for a while, she started to organize the work in this department. After a while, she started to do report finding. At the end, she is quite like, she did education, she did internal education, and she's working like something like a consultant. Some work, she's doing the job that some physicians don't do at the beginning of that. That's why? Because they did it, they asked her to take more responsibilities, they asked her, they legalized this responsibility inside the department, they put some education on her, they invested in her education, bringing her to a new role. The problem is the bridge, where we are starting to become physician and we are still technologists. It's really, sometimes it's really hard to tell. But the fact that is actually earning more money than before. That's I can assure because she talked to me, so I can assure. And that's what we talked about in a clinical career lab. Obviously, there must be space for that. For example, in Italy, there was sometimes a space for going into radiochemistry because there were lacks of people in the radiochemistry. So there was a push in developing advanced practice in radiochemistry. Sometimes doesn't agree that is advanced practice. I consider that advanced practice because we are going into some, not mainly clinical, but in some other details. That's what we talked about. The fact that probably in radiochemistry you are not earning so more money, so it's not so appealing like in the clinical development.
And with regards to CPDs, the usually physicians, while they, for example, their progress in the lifelong learning, they have something called CMEs. But the problem that, again, technologists, we would like them to have CPDs, because with CPDs, like continuation professional development points, they can really know the weak point in their skills and knowledge, try to develop it, and, for example, do more research, continuous education, attending seminars, conferences, would really add up the point. But again, we have a problem of the authorities where usually we don't have a technologists committee that back them up. So CBT, it will really not encourage them to attend these conferences because no CPDs point.
You're firing an arrow and make really, all the, the cat really bleed for that.
Yeah, I told you, do not discuss it with me.
Really bleed because it's really a terrible issue, which we are trying to come on. It's really difficult because in Europe we are not a common city, so every country has a continuing education for technologies. But well, in a lot of countries, really varies and can change for that. For example, in Italy, we have a fixed number of credits to be obtained, but they are quite all about radiographers, radiation therapists, and that. So, for example, in last year, I've been speaking at KSNMMI. I've been all around attending Congress, ENM. I have 0 credit for my country, and because I don't want to pay for online course about things that I will never do in my life, and that's okay. I'm a bad technologist. Please fire me if you want. That's my point, and that's the point of a lot of colleagues. Because why I have to do a CT about cardiovascular disease and radiographers, chest radiographers, when I work in nuclear medicine, there is no point. So it's a really a huge cut, this one, because well we have it. In Europe, there is a lot of people, but it's working really in a bad manner. It's not helping really technology practice. That's my point of view. And also, ENM Congress, we are trying every way to have a fully accredited city. But how it works? We give credit, but every country give credits for them as they want. So our course, for example, in ENM, is created 2 credits in Holland, 5 credits in France, 10 credits in Italy, 1 year's 10, 1 year's 5 in Italy. So okay, sometimes it was really better than the other, probably. I don't know. And so it's really crazy. But it's all about regulation and not having a standardization. In physician has also a problem, but have a group like UMS that decide. We don't have consensus. And without consensus, it's very difficult. My opinion, continuing professional development must be done. It's really important. But must be done really for things that happen. And I really suggest hospitals to stress that and create my association of hospitals and also association of technologists to build their own courses if possible. This is a good starting point to create also technology that this is a really good starting point. This conference is a really good starting point.
And I think that I think we need also that to discriminate the good people or those who are really working or those who are really developing themselves among the others and give them a credit, at least by CBD points and attending conferences and doing also involvement in the research work as well in the department.
Yes, well, actually, I agree with you, but discriminate the good with bad is really difficult if you don't have a really a well done accreditation system, because you can really maybe the people I buy a lot of courses. I just there sleep when I going fulfill with a friend with the help of a friend. That's I'm a good technologist. Not true. You have to show in another way, and that is difficult. It's not easy, but you have to really make something that is not like in Italy, not money related. I pay, I obtain something that's really related to the want. For example, my suggestion, personal suggestion, give credit to people that present at the conference, people that do take the work, do paper, because they're really people that won't increase their what. Yes, people that work. I want a research. I had two PET CT scanner. Which one has better image quality? Okay, do a research. This must be. A technology is doing that, putting ideas, wanting to standardize. This must be priced.
the radiopharmacy. We still have the physician is inject the patient and still the syringe we have 4 to 5 millicurie. So why we prevent the technologist from inject the patient?
Oh, I don't understand the question, sorry.
Why we prevent the technologist from inject the patient the radiopharmaceutical? Still we have the physician inject the patient and still in the syringe we have 4 to 5 millicurie. So most of the injection is not in the patient, it's in the syringe. So we have also mistakes.
But actually, I will really
Um, I may agree about what you have said, but maybe it is applied in America. Maybe because the system in America, okay, the nuclear medicine department, we have several technologists and you barely have one physician, okay? So yes, I think that, and I recommend that the technologist in America to have the facility of injecting the patient. But according to the statistical numbers that Dr. Leila has just showed us, that according to the nuclear medicine physicians in Kuwait, they are 50. Comparing to the nuclear medicine technologists who are there, they are 73. Give them some job to do. No, what I mean is that, okay, that our technologists, I appreciate, according to what I've said now, what is being run, okay, in Europe, okay, our technologists, let me talk about the graduates, they have just graduated, their level, comparing with the worldwide, it's considered to be like advanced level. So for them to seek for perfection and doing their job, I think this is more than enough for them. In my opinion, because we have 50 nuclear medicine physicians, I'm not saying just 50 physicians. 50 nuclear medicine physicians, I think we should, I mean, they have to, have to be this, one of their job description, while the nuclear medicine technologist waiting for the injection, because for some procedures, we are having like a bolus injection. You need to inject and start at the same time. I mean, our technologist is not an octopus. Okay, they need someone to inject in order that they start, the procedure. So, honestly, I appreciate Kuwait nuclear missile technologists, the Kuwaitis and non-Kuwaitis. I really appreciate what they are doing so far, their job description. I mean, what they are doing in Kuwait. When I'm comparing, I mean, I worked in nuclear medicine departments in UK, whether it was in Hammersmith Hospital, White City Hospital, Royal Free Hospital, and Royal County Surrey Hospital. Okay, and what I've seen here for the nuclear medicine in Kuwait, they are doing a miracle job. Thank you, guys. Thank you.
Yeah.
Excuse me, how many do you have in the, if I may interrupt you, how many physicians in a department on average? Sometimes we have 30 technologists, basically. Penetrating that barrier. Once you penetrate that barrier, then you are in an advanced.
Absolutely. Absolutely. But what I want to say is not that I think that as you showed, is a really, really advanced practice about nuclear medicine technologies. I'm not stating, and you have to think that injecting radiopharmaceutical, for example, nowadays there are a lot of automated injector, so it's enough that someone took the intravenous and leave the machine do it by yourself. So, for example, for PET scan, not the bolus scan, just one see one or couple of actions, but for the main PET-CT, there is a machine doing all the job, so it's not anymore eight questions to be taken on in my point of view. What I really want to stress, first of all, I want to thanks for all this really nice discussion. It was really interesting. Thanks Taiba for everything. Thanks really, and thanks to everyone for being involved. But what I really stress is about the slide that you presented before about the lack of quite like a flat life of the text. Really, I really encourage you to associate between you. I really encourage you to put your scientific, become a scientist, become something more. Because we're 8 hours a day, 9 hours a day, and a lifetime of work, doing always the same thing is really long while. It's really a long while. If you don't find in yourself, in your job, in something as a way to go to job every day despite your payment, it's really difficult to go on and give right care to a patient without being really emotionally and intellectually involved in your job. So please, really, a recommendation for that, try to do it. We really encourage as an association, technology committee, that be